it. This is my third shift in the hospital as a hospital clinical pharmacist. It was chill. I mostly shadowed the other inpatient pharmacists and figured out how to do like verification. So the providers put in the orders and we make sure that it's okay for the patient, for their weight, for their age, for their kidney like functioning. The dose is right for what we're treating. You can look at the like admission notes and all the little labs and stuff. Make sure it's appropriate for the patients. They also do a bunch of other stuff like verifying the actual like product that technicians are like compounding in the hood. There were a lot of phone calls today from the floors. The providers were asking some questions and some nurses were asking some questions with like compatibility and a bunch of other stuff. At the end of the day, I had a chance to have like a meeting with their infectious disease pharmacist, their ID pharmacist. She's really smart. She floats around at all the hospitals. So she went over how to dose vancomycin. So vancomycin is like empiric coverage for like suspected MRSA, and we can use it for like non-MRSA infections too, like if there's like an allergy or issues. But pharmacists are the ones dosing the vancomycin in the hospital. It's a little difficult to dose and it can cause some toxicities like nephrotoxicity with your kidneys and ototoxicities with like your ears. So when it went from like providers dosing vancomycin over to like pharmacist led, we saw a dramatic decrease in toxicities. So for Vanc dosing, they give loads to everyone, loading doses. 20 to 25 mg per kg once. This is the same for patients on hemodialysis. You can dose it by total body weight instead of adjusted because you cap it at 2 grams max. For maintenance dose, we use dosing body weight if it's above ideal body weight, and if it's less than ideal body weight, we use total body weight. It's like 10 to 15 mg per kg. And the dosing frequency for patients with like normal renal functioning is every 8 hours or every 12 hours. She was saying for patients less than the age of 50, they like to do like Q8 dosing, both the dose and the interval change as your like renal function declines. Hemodialysis maintenance dose is going to be like 5 to 12 milligrams per kilogram after dialysis. They use high flux filters with their dialysis, so it pulls maybe like 50% of that Vanc dose off, 10 to 15% per hour, and it's like 4 hours usually. For peritoneal dialysis, it's just the loading dose, and redose 15 mg per kg, and the trough drops below 15. It's a little difficult with continuous renal replacement therapy or CRRT. Trough goal is going to be 10 to 20. AUC goal is going to be between 400 and 600. Troughs below 20 with AUC between 400 to 600 are associated with therapeutic failure. For CNS infection, you might want to have your trough between 15 to 20 and your AUC less than 700. It has to get into the CNS past the blood-brain barrier. When you're drawing trough levels, you have to draw it when the drug's at steady state concentration. This is about 30 to 60 minutes before your 4th dose. It's a calculation you can do to figure out what your true trough level is if you draw it way too early or late. So C1 equals C2 times e to the negative KET. Be aware that older patients are going to have less frequent or lower doses. Your Vanc dose is going to depend on your age, your weight, and your renal function. Some providers round serum creatinine for older patients, some providers don't. Might be rounding down anyway on the dose when we're using clinical judgment for maintenance doses. Doses are round to the nearest 250 milligram increment. And another special consideration, patients who are obese, so BMI greater than 40, often accumulate drug with repeated dosing.